just a 30-second quick housekeeping, and then I'll turn it over to Clara. One, you should see in your chat box the sign-in sheet. Please make sure you sign in, and more important, at the end of the grand round, I will post the survey. Please complete the survey so that you can get CME credit as well as American Board of Pediatric MOC Part 2 credits. And with that, I will turn it over to Clara.
Great. Thank you so much. Thank you, Marielle, for allowing us to host this Neo Grand Rounds every third Tuesday of the month. We're here every month at 12:30 Pacific time and 15:15 Eastern Standard Time. So today on August 20th, we have Dr. Rita Ryan, who is the professor of pediatrics at Case Western Reserve University. She's also a senior attending neonatologist over at Rainbow Children's. Rainbow Babies, more like. She's a physician scientist with what I read as 194 publications per ResearchGate. Is that correct, Rita?
I think it's probably close.
Okay, so 200-ish, we'll round up. She has a research focus on pulmonary physiology, neonatal lung disease, and oxidative stress with oxygen exposure. Now, in fellowship and early on, she was mentored by one of the giants in our field, Jeff Whitsett, who in fact discovered surfactant B and C proteins. And she was previously a division chief at Buffalo, succeeding Robin Steinhorn and then handing the baton over to Satyan. So it was like a Ryan, Rita, Satyan sandwich. It's like the triple threat over at Buffalo. And she handed that baton over so that she could become department chair of pediatrics over at MUSC in South Carolina, which I think is like the East Coast USC. And she also happens to play the guitar. She's a fan of the Mamma Mia movies, both of them. And she's soon to be a first-time grandma, right? In about 2 months. So congratulations. Today she's here to talk about oxygen, friend or foe. Probably both. So I'll hand it over to Rita.
Thank you so much, Clara, for having me again. And I think I'm just hoping you can all see the main slide there, right?
Yeah.
So, yeah, oxygen, friend or foe. And yes, it is both, and what every budding neonatologist should know. And this is our new rainbow template, so you'll enjoy that, hopefully. So I don't have any financial disclosures and any relationship with anybody like that. I was the Neo site investigator here for the aflibercept trial that was here. One of the, Rainbow was one of the sites. It just got FDA approved for ROP, but I don't, as I said, I don't have any financial arrangements with anybody. I'm not against oxygen. I am against excessive oxygen. So for those of you who've been doing this for more than a few years, you know we're kind of on this roller coaster with oxygen. In the 50s, you know, we were piping it into the isolate, and oxygen is great and it saves babies. And then after a decade or so, we figured out oxygen is awful. Babies get blind. We can't have that. That's a picture of ROP if you don't recognize it. And then after another decade or two, oxygen is good, babies grow better, and the heart stays healthy. But then, well, maybe not. Oxygen is bad. It hurts the lungs and it hurts the brain. So if you think about the PO2 in the mother's bloodstream being around 100, and what's going into the uterine vein, and then into the umbilical vein, and then finally into the baby's umbilical artery levels, the PO2 is in the 20s to 30s at best. And so after birth, in a matter of minutes, the PO2 is going to increase to 80 to 100. And if you're giving supplemental oxygen, it can even be over 200. And so the fact is that just being born is an oxidant challenge. So I'm going to alert you to a couple of old reviews. They're really good, and I'm not going to have time to really go through any of this stuff. This is a really good one on sources of reactive oxygen species and reactive nitrogen species. It is focused on the lung. For those of you who are interested in the lung, it's a great little review. It's a little bit older. There's probably newer ones, obviously, but these are the ones that I found the most useful over time. And so what kind of made me start thinking about this a little bit more was 20 years ago now, a neonatologist by the name of Ola Sogstad, who kind of made me think about this differently. He kind of pointed out that hypoxanthine is increased in over a matter of minutes when you become hypoxic. And this is sort of the theoretical and experimental basis for avoiding pure oxygen for resuscitation. And they found that hypoxanthine is released into the circulation and quickly reaches very high levels during resuscitation. This is data from dogs. And then during reoxygenation, hypoxanthine is oxidized to uric acid. And in that process, superoxide is released. And this process occurs via an enzyme called xanthine oxidase. And it turns out this rate of superoxide radical production by xanthine oxidase was found to be proportional to the oxygen concentration that was present. This is mostly in vitro studies. So he sort of coined this phrase called the oxygen paradox, the discovery that cell and tissue injury are worsened if hypoxic tissue is supplemented with high oxygen concentrations, and kind of threw out this idea that maybe resuscitation with 100% is not optimal. And for those who are younger in the crowd, you're used to using room air for resuscitation now, but for many years, we used 100% exclusively for every baby in the delivery room. And Dr. Sogstad pointed out that there were tons of brain injury studies, these are all in animals, of course, showing that restoration of basic biochemical and physiologic variables after hypoxia occurred just as quickly when reoxygenation was performed with room air as when performed with pure oxygen. Now, some people, we live in the world of meta-analyses now. I'm not going to walk you through the forest plots because I think everybody knows how to look at them now. But people often say, do these meta-analyses really change practice? Do they really make a difference? And I can tell you in real time, when I saw this meta-analysis in real time 20 years ago, it definitely changed practice. First of all, this was an important outcome. This was mortality. And it showed that babies who were resuscitated in room air did better from a mortality standpoint than those in 100% oxygen. And you can see this did not cross 1, had a decent p-value, and now they start writing this under here, favors room air. So if you get confused what it's telling you, we know that it favors room air. And the Australians kind of jumped on this faster than we did, in their NRP guidelines in 2007 already said resuscitation should start with air and only use oxygen if the infant does not respond. We were a little bit later than that. And while this was going on, I was in Buffalo, as Clara mentioned, and I was working with Vasanth Kumar. He just left Buffalo to become the division chief in Jacksonville. He was a young faculty member there, and we were working in this great sheep lab that had been set up by Robin and Satyan, who you mentioned. And Satyan wasn't there at this time. He had gone somewhere else to do an interim position. But what we found was we were looking at resuscitation. So these animals got 30 minutes of room air, and then these animals got 30 minutes right after delivery of 100% oxygen. And then these two groups would get whatever oxygen they needed. And it was roughly, these are term newborn sheep, roughly about 25% oxygen. So all three groups are ventilated for 24 hours. And then this group gets 100% oxygen for the 24 hours. And then we just measured the levels of 3 different common antioxidant enzymes, superoxide dismutase, catalase, and glutathione peroxidase. And what you can see is that if you give a newborn baby sheep 100% oxygen for 24 hours, they are going to raise their antioxidant levels, which makes perfect sense. And there's also the suggestion that for glutathione peroxidase, maybe even just 30 minutes of exposure to 100% oxygen, and then measuring 23 and a half hours later, you will get a bump in their glutathione peroxidase. That was not significant, but it looked like kind of trendy. And this is in direct contrast to preterm lambs. And this was done with one of the fellows in Buffalo, and Satyan was back by that time. And we all kind of worked together on it. And same story, 30 minutes of room air, 30 minutes of 100% oxygen, 24 hours of 100% oxygen. But the difference here is these same 3 enzymes are markedly depressed in the...
It doesn't, because it's clogged. Doesn't do anything.
Sorry? Okay. So these are preterm animals, and what you can see is that we're depleting their antioxidant enzymes, so they cannot mount the same response that the full-term baby sheep can mount. And so, the point is that the preterm and the term are not functioning the same. Now, that was looking at antioxidant enzymes. We also then looked at, when Satyan came back, we had the ability to look at 5th generation pulmonary arterioles. These are arterioles taken out of the animal after these same exposure groups, but then hung in a bath. So the outcome is an in vitro outcome, but it's from an in vivo exposure. Same thing, 30 minutes of 21%, 30 minutes of 100%, and then 24 hours of 100%. And then this group is just like your average garden variety sheep walking around the farm at about 3 days of age usually. And we're looking here at a response of these vessels to known vasoconstrictors. And what you can see is the animal that got exposed to 100% oxygen for 24 hours, and then we took out their pulmonary arterioles, they have a very strong vasoconstrictor response that is significantly different from the other groups. What was kind of interesting to us is that even the group that only had 30 minutes of 100% oxygen exposure also was significantly higher than the room air exposed animals or the room air walking around animals. These three groups, of course, are ventilated for 24 hours because that's how we keep them in the sheep lab. But so just 30 minutes of 100% oxygen is causing these vessels to be, for lack of a better word, twitchy. And so they're going to be more vasoconstrictive. And when we published this and we showed it nationally and that sort of thing, people said, yeah, well, so what? You know, this is in the vessel bath. What about in vivo? So the way we did this study, Satyan was able to instrument these animals so that we could measure percent decrease in pulmonary vascular resistance. There's a little bit different paradigm here. The animals are actually randomized. Yes, we randomized our animals to 21%, 50%, or 100% for 30 minutes, a little bit after birth, and then a little bit later, a couple of little details here, and you can always read the paper for some of those details. We look to see their response now to vasodilators. So these are known vasodilators, and of course, everybody knows nitric oxide is a vasodilator. And what you can see is that the animals who were exposed to 100% oxygen and then given nitric oxide do not drop their pulmonary vascular resistance as well as the animals who were exposed to either 21 or 50% oxygen. So this is something for us to keep in mind when we have very sick babies who we're thinking might benefit from nitric oxide. Go easy on the oxygen. And then Satyan has this, and by the way, it's Satyan Lakshmanrusima, but he's like Cher. He only needs one name to talk about him. So he made this nice schematic that points out how superoxide can cause all of these effects. So first of all, it suppresses our own endothelial nitric oxide synthase, which is our endogenous enzyme that makes our own nitric oxide, let alone giving nitric oxide. Then the second thing is that superoxide and nitric oxide is also a radical. It should have a little dot here, but no one ever puts the dot in. And these two are very reactive with each other. They form together something called peroxynitrite, or ONO, and this in and of itself causes vasoconstriction. And then finally, superoxide ramps up phosphodiesterase 5. Now remember, this is the thing that we're blocking when we give sildenafil. PDE5 will suck off the good cyclic GMP that causes vasorelaxation into an inactive form. So if you get too much of this, you're going to have more and more siphoning off of the active cyclic GMP, and you will have less vasorelaxation. So that's bad too. So all of this is bad, bad, bad. So go easy on your oxygen. Now, in about the mid-aughties or noughties, I don't even know what we're calling the 2000s now, but I happened to be reviewing the SPR abstracts that year, and we got 3 abstracts that look exactly like this. So believe it or not, less than 20 years ago, we actually did not know what the normal saturations were stepwise after birth in babies. Pulse oxes hadn't been around that long. People hadn't really used them much in the delivery room. And so we actually just got this information not that long ago. And this is one that happened to be published. I'm sure the other 2 were as well. I just used the first one that I could find. And so this looks vaguely familiar to us, right? Because we now use this in our NRP targeting for babies in the delivery room. And I'm sure I'm not showing you, most of you have already seen this already. And we got the word from NRP that we're supposed to use pulse oxes, and they have specific instructions now as time has gone on for which baby you should or should not use pulse oxes. And I'll just point out that this was not an inexpensive endeavor. For every delivery room and every place to have a pulse ox was not trivial. And so this was, you know, an important change that was made, and now we have pulse oxes. Okay, so this is another review for those of you who like this kind of thing. This is looking specifically at free radical mediated oxidative stress, and this contributes to all of the what I call the abbreviation diagnoses of neonatology. All of these are associated with free radical oxidative stress. So another really good review if that's something that you're interested in. Now, I want to show you, this is a baby who died at 7 days of age, and this is from their autopsy. And you can see all these little blue dots. These are all inflammatory cells, and they're everywhere, as you can see. And what I want to show you, this was a preterm baby, and what I want to show you is that this can be completely recreated just by giving 100% oxygen or high oxygen. And so you don't need to, this animal was not ventilated. This is a neonatal rabbit who's 8 days old and exposed to 100% oxygen from birth. This was work that I did in Rochester before I came to Buffalo. And you see all these inflammatory cells in the air spaces. And they're actually also in the interstitium. They're not as noticeable, but I can assure you with special staining and stuff, we can see them very easily. So there's a lot of inflammation going on just from oxygen exposure and nothing else. And yes, there's another review. This one actually was by myself and Satyan, and this was a fellow at the time. And all the alphabet soup of pro-inflammatory cytokines. And people tell me this is still a good reference, even though it's pretty old. It has a lot of, they allowed us a lot of citation references. So it was very well referenced. But the point is that hyperoxia alone generates pro-inflammatory pathways. Now, while I was in Rochester, Carl D'Angio and I did some work together. And I want to be clear, everybody did this. We were not the only ones to show this. I just used my own slides because it's just easier for me. And what you can see is the animals who are exposed to hyperoxia here have, and I think everybody knows this now, they have alveolar simplification. And these are the room air animals on the left at day 4 and day 10. And then the hyperoxia exposed, this again, neonatal rabbits exposed on the right, on the 2 right panels. And you can imagine that this baby, or baby rabbit, I should say, has a lot less surface area for gas exchange than this animal does. And so it just tells you that if you're missing a few secondary crest chances, you're going to end up with fewer alveoli. And this has been shown over and over and over again. Now, this is another paper that really struck me. It's also from around that time and from a long time ago. This is out of the group from Toronto Sick Kids. And they did a little bit different experiment. They actually took the mouse lung out of the mouse and put it in a petri dish and exposed the lung explant to either room air or to 3% oxygen. And what you can see here is the lung that's exposed to 3% oxygen has a lot more branching morphogenesis, a lot more development, if you will, than the lung that's exposed to room air. And these are the kind of studies that kind of started to make us think, so maybe even room air is toxic to the premature lung. If you think about it, the lung is a lot more hypoxic in utero, and it's not supposed to be coming out of the mother's body this early. What about other longer-term effects of neonatal hyperoxia exposure? Yes, there are. And this is an absolutely fascinating study that I was so shocked when I saw this in real time. This was done by Mike O'Reilly. He was still at the University of Rochester, even though I had left, he was still there. And what he did was very simple. He took 1-day-old neonatal mice, and from day 1 to day 4, just 72 hours of 100% oxygen, that was their exposure. And then he put them back in the vivarium for 2 months in room air. Didn't touch them, didn't do anything. They developed normally, they ate, they grew, everything was fine. And then I don't know what made him decide to do this, to be honest with you. I never asked him. But he decided to test them with influenza A. And the black lines here, this is a survival curve. This is the survival's getting less and less and less. These are the animals who got exposed to neonatal hyperoxia. And these are the room air animals that never got exposed to neonatal hyperoxia. And you can see these animals are dying. And so what this is telling us is that just this short, relatively short amount of time of exposure to 100% oxygen is actually altering the immune system of these mice and causing them to not be able to respond to intranasal influenza and having increased death. So this was very interesting. He's been working on sort of the etiology of this and trying to understand this better. And I'm not going to go into it anymore. The point is that there are effects that you would not predict from hyperoxia exposure. And I will say that 100% is pretty high. In these older days, there were quite a few babies who did get exposed to 100% oxygen for a period of time. And even now, you think that doesn't happen, but it does happen sometimes. Obviously, we try not to do that, and we're doing a lot better. But and even higher oxygen doesn't have to be 100%. That's just the easiest thing to do in the lab. But anyway, it's affecting other systems is the point. But of course, it's also affecting the lung. And this is another study that Vasant Kumar and I did together, exposing now to 85% since 100% is such a sledgehammer. So, but what happens if we don't do quite as high of an oxygen? And these animals are neonatal mice starting at postnatal day 2 to postnatal day 14. So they're getting 12 days of 85% oxygen, or the other group is getting just, room air. Some of them get sacrificed at P14. Everybody comes out of oxygen, but some of them just go to room air until 15 weeks. So they're sitting in room air now for 3 months, and we sacrifice them and take a look at them. And a couple of findings. Now, this isn't a surprise, of course, that at 2 weeks, right at the end of that oxygen exposure, of course, they're going to have alveolar simplification. That's not a shock. But even after 3 months in the vivarium, in room air, they still have significant alveolar simplification. This doesn't go away. It doesn't get better. And what I was starting to say before, these secondary crests that you're stifling perhaps by 100% oxygen or 85% oxygen exposure, those don't get made up for. And so we still have a lot less surface area for gas exchange than we do in this animal. In addition, we did some kind of poor man measurement of looking at reactive airways disease, and you can see that at baseline, and also when you give a methacholine challenge to stimulate airway reactivity, these animals, even though this is at 15 weeks, they've been in room air for 3 months and no oxygen hyperoxia exposure. But this hyperoxia exposure in the neonatal period causes them to still have reactive airways disease, or to still have this increased airway hyperreactivity, I should say. Now, this is a little off the beaten track, but it kind of reminded me of the Mike O'Reilly paper with influenza. This is looking at RSV-associated hospitalization, and I had found this study when I was doing a late preterm respiratory problem talk. And it's kind of interesting because this is something that I can understand, how many hospitalizations per 1,000 children. So it tells you 44 for the low risk group, 562 for the BPD group. So of course, BPD is always the highest in every category. And then congenital heart disease is also on the higher side. But what was intriguing to me is that even babies who are born prematurely but do not have BPD are going to have an increased risk of hospitalization if they get infected with RSV. And it's roughly around twice. The relative risk is around 2. And this doesn't go away at 0 to 6 months of age. It's still there at 6 to 12 months of age. Now it's around 3 times the relative risk. And even at 12 to 24 months, it's still staying there. So the point is the things we're doing in the NICU are potentially affecting these babies, for a long time. And just being born prematurely, even if you don't have classic BPD, is affecting these babies for a long time. Hold on, making sure this isn't Clara telling me something important. Okay, it's not. Now I want to move over to ROP for a few minutes, and this is a very old slide. This is from Dr. Dale Phelps, who was my division chief in Rochester, and she was a big ROP person. And so this is looking at any ROP, very high in the youngest gestational age babies, pre-threshold ROP and threshold ROP in pink. Not as high, obviously, but higher still, always in the smallest gestational age babies. And I got to hand it to this ROP group in particular. They stuck together for decades, and they got every piece of information they could probably get out of their trials. So this cryo ROP study is where we got all of this baseline information about ROP and many, many things that I'm not going to actually show you, but I will show you this one interesting thing. So if you group these babies by birth weight, you can see that the bigger babies have the onset of threshold ROP sooner chronologically than the smallest babies. And this is why if you actually think about it and you're looking at your babies in the NICU, these guys get their first ROP exam later than these guys do. And this is why. But if you plot them by chronologic age, but if you plot them by corrected gestational age, or now what we would call postmenstrual age, you see that they all peak at the same time. So the onset of threshold disease is around 38 weeks, roughly from 34 to 42 weeks. So if you have a baby who's now 42 weeks or higher, their chances of getting threshold ROP, which is the more severe form that might need treatment, is pretty low. And so you can kind of feel a little bit better when you get to that point. But the point is, this is a developmental clock. A lot of things in neonatology are altered by birth. It changes the developmental clock. This doesn't. This stays exactly the same no matter when you're born. you will get your threshold ROP at the same postmenstrual age. And so the ROP people kind of use this kind of information from the cryo ROP study to begin with, and it's held true for all of these ROP studies. This is why we do our first exam, because the youngest baby to get threshold ROP in these big studies was at around 31.5 weeks. So that's when we do the first exam. And then it also points out that this period, we still have a lot of babies getting threshold ROP here, but a lot of them are going home. And so it's very important when you're talking to your parents at the time of discharge to please reinforce that they need to keep their ophthalmology appointment, because they can actually go blind if they don't see their ophthalmologist in a timely fashion. So it's very, very important. It's kind of, I used to think this was going to say the danger zone, but it says discharge home. So what is happening here with ROP? If you're not familiar with this and really understanding it, it can be very confusing. So this is the vascular retina, and this is the avascular retina. And what we're pointing to here is the retina, but cut on its side. You see it's very thin here. And what happens at some point is, the retina starts getting thicker and thicker and thicker, the whole 12 layers and everything. And so when it gets thicker like this, it needs its own blood supply. Out here, we think it is living off the choroid blood supply and getting its oxygen and nutrients by diffusion. But as it develops and gets thicker, it needs its own blood supply. And so here's our retinal vessels coming out from the optic disc. And this is what happens in the normal situation. So those keep going all the way out to the edge of the retina. With ROP, what we think is going to happen, so we're living off the choroid here. Here's our avascular retina, vascular retina. And what we think, and here's the thick retina, and now something has happened. Sometimes we blame hyperoxia for this because it's going to vasoconstrict these vessels. Sometimes it's not necessarily a hyperoxia event. It could be a new episode of bad NEC or a new episode of bad sepsis, but something happens to disrupt the vasculature here. We get vasoconstriction, and then this part of the retina isn't so bad because it's living off the choroid. This part of the retina isn't so bad because it's relatively closer to the retinal vessels. And so this is the part of the retina that's really most feeling the lack of oxygen. And so what happens is at this juncture here, we know that there are a lot of pro-angiogenic growth factors that are going to be produced. The big one, of course, is VEGF, vascular endothelial growth factor. And these growth factors are there to say, please, I need more blood vessels, I need more blood vessels. These blood vessels are actually here in this example coming out of the plane of the retina. We call that basically that stage 3 ROP. And then eventually, if all is going well, good word, this will hopefully, these vessels will continue to mature and the retina will be fully vascularized, but you'll be left with this ridge. And again, this is mostly for the fellows if you haven't heard this before. This ridge is just like a scar on your hand. It will contract, and when it contracts, the retina will lift up and you will get retinal detachment, or you can get retinal detachment. So that's why we focus on this so much. All right, so you get the idea. So cryo ROP was a very interesting study where they said, look, we're going to get, we know if we do a punch biopsy here, we're going to get VEGF. So we're going to get rid of that by freezing the retina in all these spots wherever the ROP was around the eye. We're going to freeze the peripheral part of the eye where the avascular retina is to stop this VEGF from being produced. But remember, you are also killing these cells and the baby will lose peripheral vision depending on how far out from the center of the eye we're doing the cryo ROP. And laser was never, this was studied in the big cryo ROP study. This was done quite some time ago. Laser was never studied, but the principle is exactly the same, and it seems to work very similarly. And I will tell you from personal experience, as a neonatology fellow during the early cryo times, these babies, the cryo treatment itself was pretty brutal, and the laser is a lot kinder to the baby. But you're still losing all the retinal cells there in that part of the eye. Now, for those of you who don't know, Stevie Wonder was a preemie, and he actually got his blindness from retinopathy of prematurity. So if you want to put somebody famous in one of your talks, you could use him. We know that hyperoxia suppresses VEGF, and hypoxia induces something called HIF1, or hypoxia inducible factor 1, and that will increase VEGF. And we know that high oxygen contributes to ROP, but there was some idea that maybe recovery in higher oxygen seemed better than in some of the animal models. And so this led to a study called STOP-ROP, and I got it. These people with the acronyms are pretty good. Supplemental therapeutic oxygen for pre-threshold ROP. That's how they got STOP-ROP. And in here, we see they enrolled babies who were at pre-threshold ROP, and you guys can look up what that means. I don't have time to go into the details. And this is for infants whose room air sats were less than 94%, who were going to need some kind of oxygen. And they were randomized at the time of pre-threshold ROP to either 96 to 99% or 89 to 94%. And the idea here is that, remember, living off the choroid here, if I can make this a little bit higher oxygen level, maybe this part of the retina won't feel so gypped on oxygen and won't make as much of the VEGF and as much of the growth factors. That was kind of the idea behind this study. And the results were kind of controversial. So this study was published in 2000. They had a big N. It did actually kind of seem to work. They had the rate of progression from pre-threshold to threshold in at least one eye was a little bit higher in the conventional arm than in the higher oxygen supplemental target arm. And then they did an adjustment for all of these other factors that could be contributing, a multiple regression kind of thing. And the odds ratio for progression was 0.72 with a 95% interval that just barely crossed 1. So everybody was very, upset about everything. And if you looked at some of their pre-specified severity strata, the ROP progression rates were lower with supplemental oxygen than with conventional oxygen. But again, the differences were not statistically significant. Some people looked at a post hoc analysis of the babies with and without plus disease. And the argument here was that if you have plus disease, you have a more aggressive form of the disease, and maybe this oxygen thing won't make a difference. But in the infants without plus disease, they may be more responsive to supplemental therapy. And in fact, this change from 46% progression to 32% in the supplemental arm was statistically significant in the infants without plus disease. So there's a lot of discussion about this, but the ROP people were freaked out by the effect on the lung. And so you could imagine that if you have a higher SAT target, you are going to have more babies remaining on oxygen longer. I don't think this is particularly surprising. You may even find that doctors are more willing to give medicines to babies if they have a cannula on their body than if they don't. But regardless, all of this effect on the lung was very alarming. And this whole idea of supplemental oxygen for the ROP kids kind of died. Now, I would like to point out that this study didn't randomize kids till all the way out here, 34 or 35 weeks. There was a similar study.
Come in anyway. Thanks.
There was a similar study that was done called the Boost trial. And again, these kids were randomized at 32 weeks. So this kind of left this huge, big black box of where should we target these kids' SATs? We're going to come back to the ROP thing in a minute. But this spawned a huge number of studies, a huge number of babies being in 3 big studies. The Support trial, which was run by the Neonatal Research Network, Boost 2, which was an Australia-New Zealand trial, and the Canadian Oxygen trial. I'm going to talk about Support because that was here in the US, and that's where we are. So this was published in the New England Journal, and in this study, they randomized babies from birth. I think you had to be enrolled less than 6 hours of life. And it was this gestational age, 24 to under 28 weeks. And they got randomized to 85 to 89% versus 91 to 95%. Lower oxygen sat group, higher oxygen sat group, good number of babies in each group. And the study did exactly what they predicted it was going to do. It lowered the chance of severe retinopathy of prematurity from 18% to 8%, with a relative risk of 0.52 and a confidence interval that did not cross 1. It also, by the way, decreased the rate of BPD by almost 10%. And again, here's your relative risk and here's your confidence interval. However, unfortunately, there was a statistical increase in mortality, 19.9, almost 20% versus 16% death. So a higher risk in the lower oxygen group. And this actually did not cross 1, just barely missed it, but did not cross 1. So this was obviously very alarming for everybody. And one of the things I love about this paper is they didn't just say what the targets were, they actually told us what the babies actually got. So not just the target. So I kind of put these lines in for us. So the target here is 91 to 95%. And most of the time, that group is, roughly speaking, mostly in range. The babies whose target is 85 to 89%, that's these lines. And you can see that most of them are not in that range. So that increased mortality, don't fool yourself into thinking I have to be all the way down here to get that increase in mortality. It's really much closer to our normal target of 90 to 95%. So just want to point that out and keep that in mind. Now, these three studies were pooled, the data was pooled together, and a big meta-analysis was done. This is a second meta-analysis that's a very nice readable one if you want to read something. But basically, when I look at these meta-analyses and the individual studies, I think that these are all theoretical and suggested in one study or another. But the ones I think we have really good, solid data for are the ones in red. So the risk of too low of a SAT target is death, and NEC is higher if you target your SATs too low. And the risk of too high a SAT target is severe ROP and BPD. And I can tell you that there were a lot of people that were kind of walking around the country very bragging about, oh, we target only in the 70s. And I won't name any names about which institutions these were, but probably that's not going to be what you want to do. And I think everybody's kind of stuck with the 90 to 95% range. And I think that's fine. Now, I want to mention something that's not really new. And actually, this is a paper from Rainbow, but I had it in this talk long before I came to Rainbow. And this is looking at something called intermittent hypoxemia. And basically, these are events where the saturation is below 80% for more than 10 seconds, but less than 3 minutes. And this group also looked at hyperoxemic events. This is defined as a saturation greater than 95% for more than 10 seconds. And if you look at the number of IH events per week, so this is per week, some of these babies are getting up to 600 events per week. And the other thing is that this group has studied this quite a bit, and other people have studied it too. This was the first paper that I saw that had this a long time ago, so I've just kind of stuck with it. You'll see that this increases over the first month of age, and this is very replicatable. This happens all the time. And at first I thought, hey, you guys, it's just because these kids are still intubated, because we used to keep these kids intubated for a long time. And they said, no, it's not from that. And then they do go down over time. But what is making this rise? Why is it lower here than here? I don't think even the people doing this work really understand this. But this particular group of patients was based on a cohort of 79 infants, 24 to 27 and 6/7. And then what they did was, so they had this full set data of all the babies. And then they said, well, I wonder if this has anything to do with this whole idea of severe ROP. So they broke the population into 16 versus 63 babies who got laser ROP, so got an intervention, we're calling that severe ROP, versus a group that either had no ROP or mild enough ROP that they did not get an intervention. And the things that I've highlighted in red here, none of these are too surprising that they're going to put you at increased risk for severe ROP. That these are well known. I will point out that caffeine days actually seem to be protective for the milder ROP or no ROP group. But when they split these kids into no ROP and the severe ROP group is on the top here, they had more intermittent hypoxemia events per week. You see roughly like in the 800, 600 area. These guys are more in like the 400, 200 area. So these intermittent hypoxemia events at least are associated with more severe ROP. And you can argue about, is it an association? Is it causing something? Is it reflecting something? But anyway, there is an association there. And they also looked at hyperoxemia events. And you can see in the boxes here, this is the group that got laser, the severe ROP. And the babies who had more hyperoxemia events they had less ROP, less severe ROP, I should say. So then they did intermittent hypoxemia events per day. In a second paper, they looked at it this way. And I mean, look at this, 100 events a day. This is the average of the kids who got ROP. And this is the no ROP group. So pretty dramatically different. And they always seem to start separating at the end of that second week, maybe a little bit at the end of the third week of life. And then we have a guy here named Tommy Raffet, who's kind of more interested in BPD, like some of us are. And he looked at the same cohort and said, gee, I wonder if this is true for the BPD babies too. And what you can see is they're really exactly the same until right around the end of the second week of life. And then the BPD babies have way more incidence of hypoxemia events per day than the non-BPD baby. So there's probably something very interesting here, and just trying to understand it more and wondering if we can eliminate those events, will it help eliminate some of these diseases, et cetera, et cetera. And there's people working on this. People here at Rainbow, Anna Maria Hibbs and Richard Martin have done a lot of the work with Julian DeFiore, and partnering with folks in the Prevent study, some of the UAB folks, other people have done this work as well. But to bring us back to ROP for a minute, when Julie DeFiore published that paper, Cynthia Cole, who was another ROP senior neonatologist, wrote an editorial, and she brought back this whole stop-ROP thing. And, you know, within the stop-ROP trial, progression threshold was reduced by 28%, but it crossed 1. And she feels that just because it exceeded the null by 0.01, the reduction in progression threshold in the supplemental group should not be dismissed. So kind of interesting. And I was talking actually with Satyan about giving this talk, and he and I both kind of have the same bias, which is that probably a little bit higher SAT target could be helpful, but obviously, you know, it didn't really pan out to be significant in stop-ROP. And we think other people have tried this anecdotally at their own institution, but he sent me this paper and he said, actually, this is a paper that just got published that actually did that in their unit, and they did see an advantage. So since it agreed with our bias, I threw this in the talk. This is from Riley Children's at Indiana University. Efficacy of supplemental oxygen in reducing the need for laser, or now severe ROP is being categorized by did you get laser or did you get intravitreal bevacizumab or Avastin in preterm infants with stage 2 ROP. So they looked at, we call this now here, I was just talking to somebody yesterday, we don't say quality improvement, we say improvement science study. So this is comparing the pre-protocol time period versus their post-protocol study. And in the pre-protocol time period, all their SAT targets were 90 to 95%. They made a protocol that once a kid got diagnosed with stage 2 ROP, we're going to bump the SAT targets up a little bit. They had 211 babies who were diagnosed with stage 2 ROP over the 6-year period, a little bit more in the pre-protocol than in the post-protocol period, but nonetheless, a good number of babies. And the primary outcome was the need for ROP intervention. That could be either laser or bevacizumab. And this is a little bit light to read, but it's just showing the two cohorts. They're not all that different from one another. I'll just point out the mean gestational age is around 25 weeks. These are the kids who get stage 2 ROP, and didn't really change too much over the time of their cohort study. What did change, of course, was there are going to be changes in practice over time. This is always the problem with historical controls. And what you can see here is the days on ventilator. I meant to circle the conventional days are higher, but so are the high frequency days higher. And CPAP is higher in the second cohort. So they changed, like many of us have, fewer vent days, more CPAP days. And they did take this into account in their multiple regression analysis. They looked at the number of ventilator days as one of the factors in the analysis. But what they showed, the primary outcome was your chances of needing laser or bevacizumab was 55% in the original cohort. When they changed to the new protocol, it was down to 22%, and this actually did turn out to be statistically significant. Okay, so then they did the logistic regression analysis, and they put in all of these interesting things that might make a difference to having severe ROP or not. But in the end, the one thing that they were studying, which cohort group you were in, did stay significant, significantly protective for severe ROP. So just kind of planting that idea. Maybe we need another study or another cohort study or another randomized study. I don't know. But it's just sort of a thought. Maybe you just think to yourself, okay, the kids who are stage 2 or who the ophthalmologists are worrying about, that's not the kid to let sit borderline. You know, don't let that kid sit 88, 89% all the time. That's a kid who you want to be solidly, you know, have decent saturations. Okay, so I have a couple of non-neonatal studies that I always throw them in here because often in my talks there's people from other disciplines and they think, oh, this isn't really relevant for me. So, and maybe some of this is relevant to us too. So I'll just mention these two very briefly. These are, this was in the journal Circulation, represents about 2,000 patients. These are from all the PICUs in the UK and Ireland, and they're looking at the first PO2 after a cardiopulmonary arrest, as long as the PO2 was obtained within the first hour of arrival to the PICU. And what you can see, this is the probability of death in the PICU for both graphs here. And they separate them by children with congenital heart disease and children with no congenital heart disease. And you can see a couple of things. First of all, the older you are, the more likely your probability of death in the PICU is. And in addition, you can see that the congenital heart disease kids do a little worse than the no congenital heart disease. So here's a 3-year-old no congenital heart disease. Here's their chance of death. And here's the 3-year-old with congenital heart disease. And here's their chance of death. So that is a factor that does make a difference. And then they looked at the least mortality for each age group in either the congenital heart disease or the no congenital heart disease babies or children rather, is right here. And this point worked out to be the lowest mortality risk was at a PO2 of 60 to 75. And the mortality risk increased if you went down in oxygen or up in down in PO2 or up in PO2. And so that's kind of useful information to know. And they kind of talked about in their conclusions that the optimal PO2 post-arrest was 60 to 75, and that agrees with a SAT target of around 94 to 96%. Now, there's lots of caveats with this study, and I'm not going to go into it. If you are interested, you have the reference and you can take a look at it. The second study was done in adults. These are older people over 17 years of age who had a non-trauma related cardiopulmonary resuscitation, and now we're looking at the highest PO2 in the first 24 hours post-arrest. They included the really moribund people, but they still had a very high N and a very high percentage of death. And so the interesting way that they tackled this was they kind of bucketed these PO2s from 60 to 100, 100 to 200, 200 to 300, 300 to 400, greater than 400. This is the highest PO2 post-arrest in the first 24 hours. And what you can see is that in-hospital mortality goes up with the highest PO2 being higher, and your chances of being discharged with independent functional status goes down the higher your PO2 is. And they were actually able to make a little regression analysis here, and they can tell us that a 25 millimeter mercury increase in PaO2 was associated with a 6% increase in relative risk of death. And so you can see 25, 1.06. And so, so for every increase in the increment of PaO2, you're going to have a higher chance of dying. So this seems also pretty relevant, and they spent a lot of time talking about this in their discussion. And they said, look, we don't really know what to do during the resuscitation, but we think it's reasonable to use 100% oxygen. But there's really insufficient information to tell us what to do. But once you get back your return of spontaneous circulation, you really should be aiming for greater than or equal to 94%. And the idea is to adjust the FiO2 to the minimum concentration needed to achieve an arterial saturation of at least 94% with the goal of avoiding hyperoxia while ensuring adequate oxygen delivery. So just kind of some food for thought. And this is sort of to set us up for the latest oxygen controversy, which I'm sure you've all heard about. So I showed this before. These are the SATs that we're supposed to be targeting in the delivery room. But of course, these are the SATs that we got from those studies that I showed you. They're all from full-term normal babies. What is the preterm oxygen level for resuscitation? What should we use for that? And the recommendations from NRP are 21 to 30%. And what are the right SAT targets for resuscitation? Are these the correct ones to use or not? So I'll start with the 2018 review that has this nice figure from Satyan, and it kind of talks about possible mechanisms explaining the need for higher FiO2 in preterm infants. So you kind of see where his bias is going to be in the delivery room. So these babies their lungs are stiffer. We're going to need higher pressure, due to poor compliance in the preterm lung. And the pulmonary vasculature doesn't respond in the same way as term babies. They're less responsive to endogenous vasodilators. They have surfactant deficiency. Their lungs are more fluid filled and they can't clear it as quickly. So they have poor pulmonary vascular transition and respiratory failure. And they have other reasons to have trouble. And so we do know that if you have a lower saturation and heart rate at 5 minutes, that your risk of IVH and death will increase. So this is kind of where we're starting from. Then there was a meta-analysis that was published in 2019. And in this meta-analysis, this is really from the ILCOR group, the International Liaison Committee on Resuscitation. These are the people that give us the NRP recommendations, basically. And they looked at 10 randomized controlled trials and 4 cohort studies with a lot of babies in them. So we can't say there's not a lot of opportunity to find data, But really there was no statistically significant benefit or harms from starting with lower versus higher FiO2 in the preterm population. They looked at long-term mortality, neurodevelopmental impairment, other key preterm morbidities. They really didn't find very much. And then they also threw in at the grading of recommendations assessment, development, and education. So that GRADE, that's the acronym, certainty of evidence was very low for all outcomes due to risk of bias. A lot of these studies aren't blinded. And sometimes that's tricky for these FiO2 studies. There's a lot of inconsistency and imprecision in the data that they looked at. So basically they said, look, the ideal initial FiO2 for preterm newborns is still unknown, although the majority, less than 32 weeks babies, will require oxygen supplementation. So now we have net motion, and I'm sorry this got a little messed up. It doesn't look like this, didn't look like this last night, and then I've got this thing in the way. So this net motion, talk about people coming up with an acronym. So this stands for, I'm trying to move this over. Maybe it's not blocked on your slide, but it stands for Network Meta-Analysis of Trials of Initial Oxygen in Preterm Newborns. Pretty creative, net motion. So this was published in JAMA Pediatrics, and you can see this group here. They're really mostly from University of Sydney, and then they've included the primary PIs for the randomized trials that were included. And this paper resulted in 2 recent editorials, and I'll share that information with you as well. So the main outcomes and measures here was all-cause mortality at hospital discharge. One of the positives about this particular meta-analysis is that they have individual patient data. So this allows you to kind of parse out more specific outcomes than some other studies where you can only get the really big outcomes and you can't get the individual outcomes. And they had about 1,000 babies in this meta-analysis from 12 of the 13 eligible studies, and all of these studies were randomized controlled trials. And what they found is that resuscitation with high, and this is greater than or equal to 90% FiO2 at delivery, was associated with significantly reduced mortality compared to low, less than or equal to 30% starting FiO2, with an odds ratio of 0.45, but low certainty because some of the studies, weren't perfect and that sort of thing. And also resuscitation with high compared to intermediate, which was 50 to 65% FiO2, also seemed to have a protective effect. Again, did not cross 1, but it was close, and now very low certainty instead of just low certainty. And then they had this comment that high initial FiO2 had a 97% probability of ranking first to reduce mortality. This is that ranking that happens when you do a network meta-analysis. And the effects on other morbidities were inconclusive. None of them were significant. And so they concluded that high initial FiO2 may be associated with reduced mortality in infants less than 32 weeks compared to low initial FiO2. And high initial FiO2 is possibly associated with reduced mortality compared to intermediate FiO2, but more evidence is required. I'd love to have a meta-analysis that didn't end with more evidence is required, but that does seem to be how it works. And here's the actual data as they presented it in the paper. So here's the birth weight and gestational age for the 3 groups of low, intermediate, and high. And you can see overall these babies are roughly, the median is 28.5 weeks, and the average birth weight is around 1 kilo. And here's your odds ratio, and here's your 95% confidence intervals. And you can see this one does not cross 1, but it's very close, favoring the comparator, which in this case is the high, greater than or equal to 90% FiO2. The high versus low is here, and you can see this is a little bit stronger because the confidence interval is a little bit smaller, so it doesn't cross 1, even close to crossing 1. And the intermediate versus low easily crosses 1. This is not significant. And then there are these dashed lines, and these are called prediction intervals, and thankfully they explain what these are. Prediction intervals are a measure of heterogeneity such that based on the posterior distribution of this analysis, the effect estimate of a new trial, if you did a randomized trial tomorrow, will fall within the prediction interval with 95% certainty. And you can see all of the prediction intervals do cross 1 as well. And then this is the actual mortality of the 3 groups. And I put that in there for you because sometimes, it's great to have these graphs and everything, but you just want to know what really was the risk of death. 9% versus 15 or 14% in the other groups. So the first editorial was right with this JAMA Pediatrics paper in the same journal. And this was written by Alyssa Thomas from Brigham and Women's and Elizabeth Folia from CHOP. And I think you can kind of tell where they're going to come out in the title of their paper, Uncertainty Persists. And they made two really interesting statements in their introduction. Most preterm infants require supplemental oxygen during postnatal transition, but they are also particularly vulnerable to oxidative injury to developing organs. A couple more sentences in between there, and then existing treatment recommendations therefore reflect a consensus-driven preference to avoiding exposing preterm infants to additional oxygen in the absence of proven benefits. In other words, we know there's toxicity and bad things that happen if we give too much oxygen. Let's get real proof before we tell everybody to go back to higher FiO2. And they do mention the issue of low resource settings. So I brought it up with the oximeter, but it was even more of a problem with blenders. Blenders are very expensive. And so part of the reason that the NRP dragged its feet, probably one cycle, is just to give everybody the warning. You know how they always warn you 5 years in advance if you're going to need new equipment and stuff. And so blenders, having a blender in every delivery room in every hospital in the United States was not trivial from a financial standpoint. And some of these, a very small number of these studies actually don't have blenders. So if you needed more oxygen, you went right from 21 to 100%. And so people are starting to look at the rate of titrating up or down, and could that be important? And so they felt that there were a lot of cautions in this study, lots of uncertainty in the estimates. I told you those prediction intervals cross one. If you look more detailed at the fine-tune analysis, some of the advantages are not as strong as they were presented. Balancing outcomes, meaning, you know, yes, death might be higher or lower, but there's other morbidity as well. And they pointed out that in the lower oxygen groups, BPD and ROP were lower, but it wasn't significant. In this meta-analysis, there's no long-term neurodevelopmental outcome information. There are 2 ongoing trials right now, so these authors feel that prudence suggests we wait for these trials, which I think is not unreasonable. The second editorial, and I know, Clara, you're getting nervous, I'm almost done, is from Journal of Perinatology, just came out with our favorite folks here. And preterm infants are not small-term infants should the resuscitation of a less than 26-week preterm infant be initiated with 100% oxygen. They mention the Canadian network trial that reports higher rates of mortality and neurologic injury among preterm infants once they drop down to the low oxygen recommendations. Several recent RCTs have suggested a survival advantage for starting with higher FiO2. Julie Oy showed that infants less than 32 weeks gestation that did not achieve a SAT of 80% by 5 minutes after birth had increased risk of major IVH and death. And this has become sort of the new target. At least try to get to over 80% by 5 minutes, because that we have a good amount of data now that shows that you're going to have a worse outcome. And then they point out the net motion study did say that high initial FiO2, but not intermediate, had higher odds compared to low FiO2 of achieving a SAT of greater than 80% by 5 minutes. That was one of the outcomes that they looked at in that meta-analysis. So there's a nice figure in here comparing the preterm and the term and talking about all the differences. And I will kind of run through this because you can look at the paper yourself. But of course, the lung is more immature, so you're going to have a harder time getting good oxygenation compared to the mature lung. And with that, the brain of the preterm is not the same as the term baby. And so in the hypoxic situation, this is going to suppress the respiratory drive in the preterm, but not in the term brain. In addition, in the term baby, the ductus is liable to be flowing left to right. And so red blood or pink blood is going to be able to get into the pulmonary circulation more easily. And we know that oxygenation will help dilate the pulmonary arteries. Whereas in the preterm, I don't know what happened there. Sorry. In the preterm, the ductus is liable to be left to right. And so you're not going to get that nice pink blood going over to the pulmonary circulation as quickly. And in fact, the preterm has very poor response to oxygen and pulmonary vasodilators. So these pulmonary arteries are going to stay constricted. And so you may need a higher FiO2 to kind of move some of these processes along, is basically what this is saying. So now their conclusions were that net motion only had 292 babies less than 26 weeks. And I should point out that some of these physiologic things that the group talked about is because most of the mortality is in kids less than 26 weeks. So that's why they focused their physiology discussion here on babies less than 26 weeks. But yet in net motion, in all of these 12 randomized controlled trials, there's only 292 babies out of the 1,000 who were less than 26 weeks. So my comments are in blue. So it sounds like we need to focus on this population more in future studies. That means we're going to need more centers. That means it's going to be more expensive because there are not that many babies born less than 26 weeks. The authors point out that there are ongoing studies that continue to evaluate this question, but none include a high oxygen arm. To that I say, uh-oh. And the speed of oxygen titration to meet SAT targets may be a more relevant question. That's kind of interesting. Future studies are needed and should include evaluation of multiple levels of oxygen, as well as biochemical and epigenetic evaluation of oxidative stress, etc. And until such information is available, the safest initial level of oxygen for preterm infant resuscitation is unclear, and clinicians could instead focus on titrating oxygen levels to target a minimum SAT of 80% by 5 minutes. So I feel like there's a little bit of reluctance because we're so like, no, don't go up on oxygen or whatever, that people will start turning it up when the SAT's pretty low by 10 and by another 10, by another 10. Maybe you don't have to be so shy in turning up the oxygen for your preterm babies. So in summary, ROP is still important. We still don't know the optimal timing of higher versus lower SAT targets. We do know more about the dangers of different targets. The experience of increased death with lower SAT targets in the support trial was pretty devastating for all neonatology clinical researchers, not just people in the network. And there is more work to be done about oxygen in the retina. For the lung, the neonatal lung develops best in a hypoxic environment. We're not going to fix BPD unless we can figure out how to fool the lung into thinking that it's in a hypoxic environment. But think of oxygen as a drug. It's our most common drug that we use. The effects are long lasting. Can we decrease IH events? Will FiO2 adjusters make a difference? I have no idea. They are being used in Europe. And I think that's my last slide. Thank you.
And we already have a question to all of that amazing content. Thank you so much. Oh, and we already have clapping too. I feel like
thank you for the clapping. I have to see the clapping. Okay, thank you.
Yeah, and hearts. I think Rita,
I am going to unshare and then I can see the clapping. I'm just kidding.
I think we should have given you like a whole afternoon because
no, that's okay. That's okay.
But we do have one ask so far in the chat. So any comments on the effects of intermittent hypoxia or hyperoxia to the retina, lungs, and the brain, in addition to what you've already presented? Maybe a rehash.
Well, I think the ROP and the brain is published, and when you have the PDF, you can get those papers. They clearly is an association of intermittent hypoxemia events and hyperoxemia for ROP, and intermittent hypoxemia for the lung, for BPD, risk of BPD. My understanding is that there's a paper by, I think, Christian Poets, if you want to look up the author, that did show an association between intermittent hypoxemia and later neurodevelopmental outcome. That showed a negative effect of the intermittent hypoxemia. I think that's the only paper so far that has published that, or that we have that. There are, intermittent hypoxemia. I can't see what that says. Sorry.
Alternates with hyperoxia.
Oh, you mean like the fluctuation thing? That was very trendy for a while. We thought it's the big swings that make a difference. And there may be truth to that. I don't know how carefully people have studied that particular thing. But for ROP, both intermittent hypoxemia and hyperoxemia were looked at. I don't know how easy it would be to look like, I don't know about a mid-range. I think the jury is sort of still saying we should do 90 to 95%. The death is higher if you do less than that. And I showed you it's not that much lower, the SAT targets that were in support that were associated with increased mortality. So I wouldn't go any lower from the beginning. I think once you get to stage 2 or